the R-GEMOX. So in Lohith GEMOX, they had received step-up dosing during cycle 1. And after cycle 2 and beyond, they up to 8 cycles, they received the glofitamab on day 1. And after the 8 cycles, patients could get another 4 cycles of glofitamab alone. The primary endpoint was overall survival, and the key secondary endpoints included efficacy markers like progression-free survival and complete response. And then, of course, they looked at the safety data. So as far as, so this was truly a global study. As you can see, there are quite a few Asian patients included here. Not a lot of representation of Black patients. I want to also mention here that, in terms of a number of prior lines of therapy, so about 62% had 1 prior line, and then the other, about almost 40%, had more than two or more prior lines of therapy. And this was also interesting to see that about 50% of patients had primary refractory disease. And many patients who had prior lines of treatment were also refractory to the previous line that was used before this particular trial. And about 9% of patients had received prior CAR T-cell therapy. So here are the results from the study. The green is Lohith GEMOX and blue is R-GEMOX, as you can see here. For the primary endpoint of overall survival, the data looked really, really good. It showed improvement in overall survival, where looking at at a median follow-up of 20 months, the median overall survival in the study arm was 25 months, and in the standard of care arm was 12.9 months. And so really almost doubling of overall survival, and the hazard ratio was 0.62. So these are pretty impressive results, and for some of our relapsed refractory patients. And as you can, and when we look at the complete response rate, the difference was pretty significant, of 33.2% difference between the complete response rate between the 2 arms. And considering half of these patients were primary refractory, this is pretty significant data for us clinically. And in terms of CRS, it mainly occurred in cycle 1, and then it was predominantly low grade. So that's also important. We do see quite a bit of early CRS in patients with Lohith, but it seems like when given with chemo, it was fairly well tolerated. And then the ICANS, the rate of neurotoxicity was also pretty low. So this was, again, from my standpoint, I think this is pretty impressive data. There are few patients, even those that we are considering for CAR T-cell therapy in second line, they need to be bridged with regimens. And right now, a lot of patients that we use Pola-R for, because we don't want to use bendamustine before CAR T collection. But some patients have really aggressive disease. So I'm looking forward to seeing more about this regimen, potentially for patients who really need to be bridged with something that is a little bit more aggressive than just Pola-R. Okay, so the next DLBCL study is an ASCO late-breaking abstract. This was brentuximab in combination with R-squared, that is lenalidomide and rituximab, compared with R-squared in relapsed refractory diffuse large B-cell lymphoma, and this is the phase 3 Echelon 3 study. The key inclusion criteria, what I want to highlight here, is that they needed to have at least 2 prior lines of therapy. They needed to be ineligible for or relapsed after stem cell transplant or CAR T-cell therapy. But as you can see here, there was, even though it was stratified based on CD30, there was no CD30 expression was not required for enrollment. This is a bit of a change from the prior Echelon trials, which required CD30 expression and also as high as 10%. So I found that pretty interesting. And then the results were stratified based on CD30. As I mentioned here, it's comparing BV R squared with R squared. Right now, we are not really using R squared for our DLBCL patients. We do use a similar regimen called Tafa-Len. It has been studied in DLBCL, but it's not. We use it pretty commonly for our indolent lymphomas, but not so much in DLBCL. So this is interesting to see how BV can make it a little bit more relevant. Primary endpoint was overall survival. So just looking at this, these are our elderly patients with the median age of over 70 years. And I think they were heavily pretreated. As I mentioned, the trial required at least 2 prior lines of therapy. And you can see here about a third of the patients had prior CAR T-cell therapy, and then about 15% had prior BiTE, and around 10 to 15% had prior stem cell transplant. That is autologous stem cell transplant. There was a balance. We tend to think about lenalidomide being more effective in non-GCB subtype, but this study did include both GCB and non-GCB, pretty balanced. And as I mentioned, so it included patients regardless of CD30 status, and majority of the patients actually had CD30 expression of less than 1%, which classically has been described as CD30 negative disease. And as you can see here, this study also included over half of the patients were primary refractory. So with this study results, they did meet the primary endpoint of significant improvement in overall survival. As I mentioned, not many of us use R-squared in DLBCL, but clearly adding BV in this fairly refractory population did give us an overall survival of 13.8 months with a progression-free survival of, median progression-free survival of 4.2 months. And what I wanted to really say here, that these patients, while R-squared did not work in patients who had received prior CAR-T, but BV R-squared did have efficacy in that subgroup. And then ironically, patients with less than 1% CD30 actually had better response if you just look at this particular plot. Again, so in the interest of time, I just want to skip to there were no new safety signals when comparing BV R-squared to R-squared. And I think this provides a viable chemo-free option, would make R-squared a little bit more relevant in this population. And it was interesting for me to see that the responses were irrespective of the CD30 expression, which is really helpful to know. And this is especially would be a post-CAR-T, post-ASCT relapse option, especially for elderly. And then finally, for the last study for DLBCL, I just wanted to mention this was published as a single-arm study in NEJM. This is a chemo-free regimen looking at venetoclax, ibrutinib, prednisone, obinutuzumab, and lenalidomide in patients with relapsed refractory DLBCL. And the data was pretty, it was pretty impressive for patients who had non-GCB subtype with overall response rates and complete response rates of 62%, as well as there was a signal of activity in the BCL2 subtype of diffuse, the BCL2 subtype of high-grade B-cell lymphoma with double-hit lymphoma, basically, with BCL2 rearrangements. So again, I think we want to see more data about this. This is an excellent paper for anybody who wants to check it out. All right. So with that, I'm going to shift gears to classical Hodgkin lymphoma, and I just wanted to highlight one study here. So this was a late-breaking abstract looking at the tolerability and efficacy of BRCAD versus BRCOP in advanced stage classical Hodgkin lymphoma. This is the German Hodgkin study group HD21 trial. So this looked at this new regimen called BRCAD. Escalated BRCOP is a regimen that is used very, very commonly in Germany and in Europe, but not so much in the US. And it is known to be, for advanced stage Hodgkin lymphoma, it is known to be very effective, but it has high toxicity, especially in terms of second malignancies, also infertility. As many of these patients are young, that is definitely a very clinically important toxicity. So what they decided to do is they remodeled BRCOP and made a few changes. So what they did was they dropped the bleomycin, they reduced the dose of etoposide. The doxorubicin was a little bit more intensive. Cyclophosphamide remained the same. They dropped the vincristine. They added brentuximab. They dropped the procarbazine and instead used the carbazine. And then, of course, the steroids. So this was, the idea was to reduce some of these clinically relevant toxicities that we have always been worried about with escalated BRCOP, and that is part of the reason we don't use it in the US. So this one, this study basically, they started with, it was a PET-adapted regimen. They started with either 2 cycles of BRCAD or BRCOP. And after 2 cycles, the PET scan, based on the PET scan, they either gave just 2 more cycles of the respective regimen in patients with PET-negative disease, and those with PET-positive disease got 4 more. So I just want to highlight here, there were some patients who were able to get away with 4 cycles of this regimen, even with advanced stage disease. And the co-primary objectives were looking at the superior tolerability, and this was a non-inferiority design trial. So just what I wanted to highlight here is that median age was young, as expected, to 31. It included patients up to 60 years of age. And again, it's not a very diverse population, which we would expect, and they included patients with advanced stage disease from 2B to 4B. And about a quarter of the patients had high-risk IPSS. So you can see here, in the PET scan after 2 cycles, the complete response rate was about 64%. It was matched in the 2, it was similar in the 2 arms. And then also, when we look at the overall, these were their side effects of interest or adverse events of interest. And it showed fewer patients with grade 4 cytopenias, as well as overall, the organ toxicity, looking at everything, it was kind of matched. But overall treatment-related morbidity was about 40% compared with 60%. Interestingly, what I saw was that, so very few patients with BRCAD actually had to drop brentuximab due to neuropathy as compared to vincristine and BRCOP. This is pretty interesting because we see in our patients getting BV AVD, a lot of them have to end up dropping or dose reducing brentuximab, and this makes us think that maybe it is the combination of vinblastine with the brentuximab that is causing so much more neurotoxicity with that regimen. So these were very impressive efficacy results at a 4-year, they had a 4-year estimated PFS of 94% and OS of 98% with the, sorry, this is kind of flipped. This should be BRCAD. It was showed a superior median PFS as well as a superior overall survival. And then as I talked a lot about the gonadal function, it really did, it was as expected, looking at the number of cycles and the effect of age. This basically looked at the time to recovery of FSH, and this period was much shorter and more complete in patients who received either 4 or 6 cycles of BRCAD as compared to BRCOP. So clearly a very important change. So again, I think this is impressive data for safety and efficacy and an option of young individuals, for young individuals with advanced stage disease. And there's also the possibility of receiving only 4 cycles if these patients get early PET2 CR with BRCAD. So with that, I just want to kind of conclude by giving my key takeaways from these studies. I think upfront treatment combinations using BiTE therapy can build on pola-R-CHP, and we are looking forward to enrolling patients on the GLOFIT pola-R-CHP trial that Scott is leading here. Also, combining BiTE with chemo in relapsed refractory disease may provide effective option both as a bridge to CAR-T as well as a standalone option. I think BVR squared is a very viable option in elderly patients. We definitely want to see more data and the paper before we can bring it to more mainstream. But it's really a viable option irrespective of CD30 expression. Again, the chemo-free VIPOR regimen holds promise for non-GCB subtype and double-hit lymphoma with BCL2 rearrangement. And then again, as we saw, thankfully with classical Hodgkin lymphoma, Nivo AVD data came out to be very impressive last year at ASH, and now you can see that BrioCAD is another option, and so we can really tailor treatment for these patients. Thank you.
Hey, well, good afternoon, everyone. As Scott mentioned, my name is Sabrina Browning. I'm faculty here at Yale in the Myeloma, Multiple Myeloma, and Gammopathies program, and I'm going to spend some of our time touching upon a few of the top ASCO abstracts in myeloma. And these are my disclosures. So as many of you may know, myeloma is a neoplasm of clonal plasma cells, and it remains incurable and is quite heterogeneous between patients. Fortunately, as a result of a number of different diagnostic and therapeutic advances, our patients with myeloma are living a lot longer, even some over a decade. But inevitably, our patients relapse, and many of them die of their disease. And so this leaves us with a number of different areas of unmet need, some of which I'll touch upon today. These include upfront treatment for patients deemed ineligible for transplant, the movement of immunotherapy earlier in disease course, and specifically anti-BCMA or B-cell maturation antigen immunotherapy, and then a hard-to-treat population that we refer to as functionally high-risk myeloma. So the abstracts will touch upon these three today. So this first abstract was presented by Dr. Facon from the French myeloma group, and it was an interim analysis of IMROSE. IMROSE was a phase 3 global prospective randomized trial that recruited 446 patients deemed to be transplant ineligible, either because they were over the age of 65 or due to comorbidities, and all patients were less than 80 years. And patients were randomized in a 3-to-2 fashion to receive a common backbone of bortezomib or Velcade, Revlimid or lenalidomide, and dexamethasone, plus or minus our anti-CD38 monoclonal antibody isatuximab. In the induction phase, patients received 4 cycles every 6 weeks, and then there was a continuous or maintenance phase where patients received on the treatment arm isatuximab in combination with Revlimid and dexamethasone. And patients on the control arm in the continuous phase, if they had biochemical or clinical progression, were able to cross over to the treatment arm. This treatment was continued until progression of disease or unacceptable toxicity, and you can see the primary endpoint here was progression-free survival with a number of key secondary efficacy endpoints as well as overall survival. And a few things to point out in terms of the treatment. So compared to our other anti-CD38 monoclonal antibody, daratumumab, currently isatuximab is given through intravenous route. In this study, it was given weekly for cycle 1 and then every other week, cycles 2 through 4. And in the IMROSE trial, bortezomib or Velcade was given subcutaneous twice weekly as opposed to the once weekly Velcade that we generally give in our clinic. So the baseline characteristics on the study were balanced between the two arms. About a quarter of patients were between the age of 75 and 80, and it's important to know that on the treatment arm of isatuximab, Velcade, Revlimid, dexamethasone, about 2/3 of patients had high-risk cytogenetics inclusive of chromosome 1 abnormalities. And as you can see here on the left, at a median follow-up of 5 years, we saw a significant improvement in progression-free survival from 45% to 63.2% in the treatment arm, with a hazard ratio of 0.6, translating to a 40% reduction in risk of progression or death. And the median progression-free survival on the isatuximab arm was not reached. We saw this progression-free survival benefit across most subgroups. Important to know that the hazard ratio for those with our standard high-risk cytogenetics was close to 1, so less of a benefit in that population. And as you can see here on the right, overall response rate between the two were similar between the two arms, but the depth of the response was significantly improved in the isatuximab arm. So rate of complete response or better was 74% compared to 64%. And we saw improvement in minimal residual disease negativity status, which is an increasingly important marker in myeloma, and now also approved to be used as a marker in clinical trials earlier to allow for quicker approval of our myeloma drugs. And so you can see here on the right that patients that received the isatuximab had a sustained MRD for more than months that was almost double those who did not receive the isatuximab. So in terms of safety, with our anti-CD38 monoclonal antibodies, it's not uncommon for us to see a higher risk of neutropenia and infections, in particular upper respiratory infections, including pneumonia. As you can see here on the bottom, there was an increase in grade 5 treatment emergent adverse events in the treatment isatuximab arm, which was explained by the authors in terms of a significant increase in treatment exposure in this arm. So patients on the isatuximab arm received treatment for a median of 53 months compared to 30 months. And so when this was adjusted for exposure, the event rate per patient per year was similar between the two arms. There were also side effects, including diarrhea, peripheral sensory neuropathy included here. And then in terms of the actual infections itself, when also adjusted for exposure, as you can see, there was similar rates between the two arms. So understanding the limitations and that we generally do not like to make direct cross-study comparisons, I've included some of our pertinent trials here in transplant ineligible to give us some more understanding of really how to apply these for our patients in the clinic. So we talked about the IMROSE study and progression-free survival benefit. Overall survival data with IMROSE is still immature, but there is a trend towards improvement with the isatuximab arm. The benefit study was also presented at ASCO. This is also a phase 3 trial that looked at the same quadruplet, isatuximab VRd, but compared to a different triplet of isatuximab, Revlimid, and dexamethasone. Survival data is also immature here, but we did see improvements in MRD negativity. And then many of you may be familiar with the MAIA study, which has resulted in our current standard of care for most transplant-ineligible patients being the triplet daratumumab, Revlimid, and dexamethasone. In this study, it was compared just to a doublet as opposed to the IMROSE and the benefit study, but we saw impressive hazard ratios for both progression-free survival and overall survival. And then the last study here, the SWOG 777 study, is an older trial out of which our prior standard of use of VRd came. But a couple of important things to note about this study was that the median age in the study was actually 63 years, which really does not represent our transplant ineligible population today. And while there was overall survival benefit in all comers, this was not significant in patients who were over the age of 65. So my takeaway from this is really that our best treatment for transplant-ineligible myeloma patients really should include an anti-CD38 monoclonal antibody. I think we've really moved away from the VRd backbone. So in conclusion, IMROSE was the first global phase 3 study of an anti-CD38 monoclonal antibody combined with VRD. And we saw a significant reduction in the risk of progression or death at 40%, as well as very deep and sustained clinical responses. So again, in older patients, there is importance to using really our best myeloma agents up front, which seem to be the anti-CD38 monoclonal antibodies, in comparison to our transplant-eligible patients who may have more opportunity to receive further therapy later in disease course. This may be limited in our older, more frail patients. But importantly, I think we have to consider with these patients both dose intensity, including the frequency of certain agents, such as Velcade, which we generally use once weekly to with good efficacy and reduction in side effects, including peripheral neuropathy. And then also consideration of the number of drugs, not so much based on transplant eligible status, but more on the patient characteristics and frailty. And the safety profile was really consistent with the addition of isatuximab, and the longer the imbalance in side effects were thought to be more related to treatment exposure. So this data was published in the New England Journal of Medicine in June around the time of the ASCO meeting, and then as of last Friday, actually was approved by the FDA for treatment of transplant-ineligible patients with newly diagnosed myeloma. The second study that I will discuss is the DREAM-8 study, which was presented by Dr. Suzanne Trudel. This is an ongoing phase 3 randomized open label study that evaluates the antibody drug conjugate against BCMA or B-cell maturation antigen belantamab mafodotin. And this was given in combination with pomalidomide and dexamethasone, and then compared to pomalidomide, Velcade, and dexamethasone. Belantamab mafodotin was given accelerated approval back in 2020, but then unfortunately was removed from the market in 2022 due to inability to meet the primary endpoint in the DREAM-3 study, which was progression-free survival. And the importance of this drug in this trial is, as we discussed, with using more drugs up front for both our transplant-eligible and transplant-ineligible patients. As you can imagine, at first relapse, we're seeing more patients who are at least triple-class exposed, if not triple-class refractory. And so having agents that have different mechanisms of action is really important. So there were 300 patients that were enrolled in this study. And again, were randomized 1-to-1 to either PBD or PVD. And belantamab mafodotin is given IV. In the study, it was given 2.5 milligrams per kilogram during IV during cycle 1, and then the dose was reduced and given Q4 weeks, cycle 2 onward. And the primary endpoint was progression-free survival. Similar in this study, the baseline characteristics as well as prior treatments received were well balanced. The majority of patients received one prior line of therapy, and most were lenalidomide refractory, which is reflective of the population that we often see at first relapse. Although only a quarter of patients were anti-CD38 exposed and or refractory, which again is a little bit different than what we're seeing kind of in real life now. So as you can see here, again, we saw an improvement in progression-free survival. This was after follow-up of almost 2 years. The 12-month progression-free survival was 71% in the treatment arm, and the median progression-free survival was not reached, with a hazard ratio, as you see here, of 0.52, so about a 50% reduction in risk of progression or death. And again, this progression-free survival benefit was observed across subgroups, including our patients that are lenalidomide refractory, with a hazard ratio of a little under 0.5. There were about 10% of patients that had extramedullary disease in this study, and they did not see a significant benefit. So again, a population of high-risk myeloma patients that are still an area of unmet need. Similar overall response rates were close in the two arms, but there was a significant increase in complete response rate or better. And again, minimal residual disease in those individuals who have complete response was almost fivefold in the patients that received the belantamab mafodotin, pomalidomide, and dexamethasone. And median duration of response was also higher in the treatment arm. So side effects that were seen included neutropenia, thrombocytopenia, and grade 3 or more infections, but were comparable in both arms. And then a unique side effect with belantamab mafodotin is ocular side effects, which are thought to occur secondary to the cytotoxic payload MMAF, which impairs corneal epithelial cell function. And so there's a number of ocular adverse events that we see as a result of belantamab mafodotin, but as you can see here, occurred in 90% of patients, although grade 3 or higher was only in 43% of patients. Over 80% of patients had resolution of these adverse events back to baseline, and over 90% had some improvement. But it did result in significant delay in dosing or reduction in dosing. So again, these visual acuity changes are reversible in most patients and only led to treatment discontinuation in 9% of patients in the belantamab arm. So in conclusion, BPD demonstrated statistically significant and clinically meaningful reduction in risk of disease or progression or death. And this was in patients with relapsed refractory myeloma after one or more lines of therapy. We saw clinical responses that were deep and durable, and there again is an early trend in overall survival benefit, although this data remains immature and follow-up is ongoing. And the safety of belantamab mafodotin, it's similar to what has been seen in prior studies, has a high risk of ocular adverse events, although they are generally reversible and can be managed with reduction and delay and dose reduction and dose holds. So this data was also published in the New England Journal of Medicine around the ASCO meeting. And similar to DREAM-8, there was a second study that was presented at ASCO, DREAM-7, where belantamab mafodotin was combined with Velcade and dexamethasone and compared to daratumumab, Velcade, and dexamethasone, and we saw similar improvement in efficacy. So the combination of these studies looking at belantamab in combination, hopefully will lead to the reemergence of belantamab in the US market. And then last year at our ASCO review, I presented this slide to talk a little bit about T-cell redirection therapy. And I pointed out that we had 2 anti-BCMA CAR T-cell products, 2 anti-BCMA bispecifics, and then talquetamab, which is a bispecific antibody that targets GPRC5D on myeloma cells. And all of these at the time were approved for relapsed refractory myeloma after 4 or more lines of therapy. But since that time, as of April, we now have approvals in earlier lines of therapy for our CAR T products. So cilta-cel is approved now for relapsed refractory myeloma after 1 or more lines of treatment. This includes a PI, an IMiD, and refractoriness to lenalidomide. And then ide-cel is approved after 2 or more lines of therapy in patients who have received an IMiD, PI, and anti-CD38 monoclonal antibody. So allows us to give these effective CAR T products to our patients sooner. And we'll talk a little more about this. So in this last abstract, I wanted to review the CARTITUDE-4 study. There was a post-hoc subgroup analysis that was presented at ASCO looking at specifically patients who have had 1 or more lines of prior therapy, and as well as patients that are functionally high risk. And we define this, or this was defined in the study, as progressive disease less than or equal to 18 months after transplant or after start of induction therapy in those patients who did not receive transplant. So the CARTITUDE-4 study was a phase 3 randomized open label study comparing a single infusion of cilta-cel, our anti-BCMA CAR T, versus standard of care, which was either daratumumab, pomalidomide, dexamethasone, or pomalidomide, Velcade, dexamethasone. And this was in lenalidomide refractory patients who have received 1 to 3 prior lines of therapy, and previously published or previously presented data showed significant improvement in progression-free survival, depth of response, and a favorable safety profile, which led to the approval earlier in disease course. This particular abstract looks at the 136 patients who had received 1 prior line of therapy, 40 of which were functional high risk and received cilta-cel, or were intended to receive cilta-cel, and 39 patients that were functionally high risk and were on the standard of care arm. So the baseline characteristics, again, generally well balanced between the 2 arms, including in those that were functionally high risk. Important to know, as you could imagine, in patients who are progressing earlier in their disease course, this population is often enriched with other high-risk features. So about a third of patients had 2 or more high-risk cytogenetic abnormalities. The majority of patients did have a transplant, although a little bit different than our current clinical practice. There was a low anti-CD38 monoclonal antibody exposure, actually less than 5% on both arms. As you can see here, we saw improvements in complete response rate, so 67.5% on the cilta-cel arm versus 38.5%. And impressively, a significant improvement in overall MRD negativity, so 65% compared to 10.3%. And these were both in the population of patients with functionally high-risk disease and early progression. And then as you can see here on the right, at a median follow-up of about 16 months, the 12-month progression-free survival was 77% in the cilta-cel arm versus 49% in the standard of care arm. So this was, again, an impressive hazard ratio of 0.27. So in terms of adverse events, so there are with CAR T products, obviously adverse events of interest. These include cytokine release syndrome or CRS, ICANS. With cilta-cel in particular, there are more unique neurologic side effects. I think one that has been of major discussion are the movement and neurocognitive treatment emergent adverse events like Parkinsonism, because I think we have actually seen these in our patients. But as you can see here, all patients that received cilta-cel did have a grade 3 or more treatment emergent event. 40% of these were serious. CRS did occur in about 2/3 of patients, but none of them were grade 3 or 4. ICANS was less frequent in 5% of patients, and we actually, in the study in the functional high-risk population, there were no patients that had the movement and neurocognitive treatment emergent adverse events. There were 11 deaths on the study in both arms. The majority were the patients that were functionally high risk, and of the patients that were intended to receive cilta-cel, 2 of the 7 that died actually didn't end up getting the cilta-cel infusion. And then another adverse event of interest are second primary malignancies. So there were 3 in the cilta-cel arm compared to 2 in the standard of care arm. 1 on the cilta-cel side was a peripheral T-cell lymphoma, unspecified. So in conclusion, with a single infusion of cilta-cel, there was a reduction in risk of disease progression and death compared to standard of care of about 65% in patients who have received 1 prior line of treatment. And then in these hard to treat patients that are functionally high risk, 73% reduction. And we saw deeper and more durable responses. And there were similar rates of CRS and neurotoxicity, and these were generally low grade and manageable. There is some preliminary data to suggest that patients who have better disease control at the time of CAR T may be able to tolerate it better with improved safety. And so there are thoughts that if this is happening earlier, and if we're giving patients these CAR Ts earlier in disease course where we have better bridging therapies and potential to better control their disease, that might reflect some of the improved safety that we see here. So to summarize these 3 abstracts, in non-frail, newly diagnosed patients that are less than the age of 80, we're really considering anti-CD38 monoclonal antibody in combination with VRd as a quadruplet. And I wrote non-frail here, although currently the International Myeloma Society meeting is occurring in Brazil right now, and there is some data being presented from the IMROSE study on frail patients that show improvement in terms of efficacy and also safety. So we may be able to extend some of this data to our frail patients as well, but I think importantly, we should be using our best anti-myeloma agents up front for these transplant-ineligible patients. Again, anti-BCMA antibody drug conjugate, belantamab mafodotin-based triplet regimen show significant improvement in terms of efficacy and seem to be well tolerated, although I think there needs to be more thoughts and discussion about how to dose and how frequently to dose and at what dose to give these drugs to try to reduce the risk of ocular toxicity. And then lastly, cilta-cel has demonstrated really significant and outstanding efficacy, including in early relapse and with these challenging to treat patients that have functionally high-risk disease. And as mentioned, we may have some more options in order to get their disease under control prior to CAR T when we're using these earlier in disease course. Thank you.
Good afternoon, everyone. My name is Nikolai Podoltsev. I'm the malignant hematologist dealing with myeloid malignancies. So I selected to focus beyond ASCO 2024 and specifically on hot topics on myeloid malignancies. So there'll be few things about ASCO, but a lot of them will be about ASH 2023, about EHA 2024. So these are my disclosures. So this are big three in myeloid malignancies: myeloproliferative neoplasms, myelodysplastic syndrome, and acute myeloid leukemia. So I'll talk a little bit about, all of them. And MPNs are divided in Philadelphia chromosome negative and positive, and Ph positive is CML. Ph negative classical MPNs are polycythemia vera, essential thrombocythemia, and myelofibrosis. So when I'm going to talk about MDS, I will mostly focus on low-risk disease management. That's kind of where the most developments are happening right now, which led to approval of medications we're currently using in clinical practice. And when I'm going to talk about acute myeloid leukemia, I'll be talking about specific subtypes, AML with KMT2 rearrangement, which is about 10% of all AML patients. And then I'll mention briefly AML with NPM1 mutation, which is about a third of patients with AML. A lot of medications I'm going to be talking today are not chemotherapy. They have different mechanism of action, so I'll focus on mechanism of action for this exciting new drugs we're using in practice, or drugs which are approaching approval by FDA. So the first one I'm going to talk about is polycythemia vera, and the drug is rusfertide, which is hepcidin mimetic. So hepcidin is master regulator of ion transport, and it internalizes ferroportin, shutting down transportation of ion from macrophage through duodenal enterocyte and out of hepatocyte. So is hepcidin mimetic rusfertide. So it limits access of ion to erythropoiesis, and similar to phlebotomy, basically decreases hematocrit, but doesn't make patient iron deficient because this iron remains in the body. And we say that the doors are closed, but the windows are open. That means some iron is still accessible for cells which need it for other things than erythropoiesis. So this particular study called REVIVE is a phase 2 trial, which was presented at ASH 2023 and EHA 2024, and was published in New England Journal of Medicine a few months ago. It had 3 parts: dose finding part number 1, part 2 blinded withdrawal, and part 3 open label extension. And this is the focus of EHA presentation by Dr. Kremenskaya. So in first part, dose finding period, pretty much all of the patients who were enrolled, and these are patients who required phlebotomies at least 3 times for management of their polycythemia vera in preceding 3 months, became phlebotomy-free, therapeutic phlebotomy-free. So the second part of the study is the main part, and the primary response here is hematocrit control, less than 45% is what our target is for PVera patients, absence of phlebotomies, and ability to complete this part of the study. So this primary efficacy endpoint was accomplished by 60% of patients who were randomized to continue receiving rusfertide. Only 17% among patients who were randomized to placebo. And so you can see how those patients who were withdrawn from rusfertide treatment had increased hematocrit, and then with open label extension, all of them again regained control after rusfertide administration. So this exciting new class of drugs, and rusfertide is the first one, which patients are using as an injection. They self-inject this drug once a week. It allows us to accomplish hematocrit control without therapeutic phlebotomy, which may be bothersome to patients, as well as decrease problems related to iron deficiency, which may lead to many symptoms, including significant fatigue, for example. Moving on to the next classical MPN, myelofibrosis. The interesting thing about this disease is the enormous drug development which is occurring in the last 10, 15 years. So there are about 3,000 patients diagnosed with this malignancy, and prevalence is about 16,000 in the United States. So it's relatively infrequent disease, but nevertheless, we saw enormous number of drugs being developed, and 4 were approved since 2011 when ruxolitinib, Jakafi was approved. We also had approval of fedratinib, pacritinib, and momelotinib. all of these drugs, they are all JAK inhibitors, and so they're right here. So there is a lot of drug development going on beyond JAK inhibition. So I would like to focus on a few of them. And specifically, I'll start from selinexor, the study which is opened at Yale in a frontline setting, where selinexor XPO1 inhibitor approved for myeloma is being combined with ruxolitinib. So there's promise that not only control of spleen size and symptoms will be accomplished, but also the disease course will be modified. So this is out of classical MPNs. This is the most lethal disease with median survival of only 6 years. So disease modification is certainly desirable, hoping that we can prevent the evolution of myelofibrosis into acute myeloid leukemia and decrease mortality. So a couple of other drugs which are on the slide here. So the imetelstat, which is circled, is being explored in a phase 3 study. This is beyond the first line treatment of myelofibrosis, and this is telomerase inhibitor. The drug, the interesting part to this study is that this is the first study in myelofibrosis where overall survival is primary endpoint. This study is also going to be available at Yale. I'm hoping will open within a month. Finally, we are excited that there is immunotherapy being developed in the field of MPNs, and we have calreticulin mutated patients, both ET and myelofibrosis patients. About 25% of these patients will have calreticulin as the main driver of their disease, and as the result, there is expression of abnormal calreticulin protein on the surface of malignant cells. Apparently, it is immunogenic, and hence the ability to develop immunotherapies, including antibody to calreticulin, as well as a BiTE against calreticulin. Both studies are currently enrolling patients in phase 1 trials. So I want to talk about pelabresib. This is the BET inhibitor, and it has been studied at Yale as part of MANIFEST-2 trial. And it is a combination of pelabresib with ruxolitinib in the frontline setting. So this study was presented at ASH 2023, and then the updates were presented at EHA 2024 by Rajit Rampal. So the primary endpoint for this trial was SVR35, with spleen volume reduction by 35%. Response was assessed at 24 weeks. And response was significantly better when looking at pelabresib with ruxolitinib versus ruxolitinib with placebo. So you can see that the difference is absolute difference about 30%, and it is significant. So the secondary endpoint is total symptom score change from baseline at week 24. And the absolute number of improvement was better for pelabresib plus ruxolitinib, but it was not significant. So the update at EHA 2024 looked at assessment without fatigue being part of the calculation. And, fatigue ceiling is one of those things which is being discussed in the field of myelofibrosis endpoint as something which may certainly be limiting in assessing its ability to help these patients with other symptoms. So if you take fatigue out, there was a significant improvement in symptoms with this combination when compared to placebo plus ruxolitinib. So this drug is being evaluated by FDA for approval. Additional data is being collected, so we don't really have a timeline for this approval, but this is something we're excited to see, and we continue to follow these patients. So I would like to switch gears to another myeloproliferative neoplasm, now pH positive, so chronic myeloid leukemia. This is the study which was presented at ASCO 2024, and the results were just published last week in the New England Journal of Medicine. So, as you know, a lot has been accomplished in the field of CML. We have right now 6 tyrosine kinase inhibitors approved, including 4 of them in the frontline setting. And this particular study called ASC4 First looked at asciminib, a new type of tyrosine kinase inhibitor in the frontline setting. So how is it different to our old tyrosine kinase inhibitors, which you can see here on the slide? So first line imatinib approved since 2001, and then there are approvals for dasatinib, nilotinib, and bosutinib in the first line setting. Ponatinib is not approved in the first line setting. It's a third generation tyrosine kinase inhibitors. All of these drugs attach to the ATP pocket of tyrosine kinase protein and block its activity this way. Asciminib is actually first-in-class allosteric inhibitor, which is a STAMP inhibitor, specifically targets the Abel-Myristoyl pocket. Really inventive way to call this medication mechanism of action. So, but you can see the pocket is different, and it works when you have mutations which do not allow attachment of classical TKIs to the ATP pockets. And also, this myristoyl pocket is not as commonly present in different tyrosine kinases as ATP pocket, and so side effect profile of this new drug may be better than side effect profile of other tyrosine kinase inhibitors. So this particular study had two strata. It randomized the newly diagnosed patients with chronic myeloid leukemia to asciminib and imatinib, or asciminib and second-generation TKIs. But the stratum with second-generation TKIs included all drugs, including imatinib. You can ask me why company decided not to randomize against second-generation TKI. You can only guess why, but they didn't. So this first graph represents comparison of asciminib, major molecular response at 1 year at 48 weeks to the major molecular response in all other treated patients, where investigators were able to choose either imatinib or second-generation TKI for its management. And you can see the difference was significant, 49% versus 67%. The second stratum was just against imatinib, and here, obviously, major molecular response was less because it's a first-generation TKI, which is less potent, at 1 year, 40% versus 69% for asciminib-treated patients. So the side effect profile for asciminib was favorable, and the drug is heading to approval and most likely will be approved before the end of the year. The one problem I see with it is financial toxicity. The cost of one pill is about $360. So, and patients usually take 2 pills a day. So this is in the environment when imatinib is generic, and the cost of that pill per month is $36. And second-generation dasatinib will be generic next month. We don't know yet how much it was going to cost. So I'm moving to the next myeloid malignancy, which is myelodysplastic syndrome. And here, I just want to highlight a couple of things. So the drug development in MDS had this window where nothing happened between 2006 and 2020. And then starting in 2020, there were few drugs which got approved. Higher risk patients are on top and lower risk patients on the bottom. So we're going to focus on 2 drugs, luspatercept and imetelstat, which are approved for management of low-risk patients based on the studies which were conducted in our center, as well as many others. So first of all, luspatercept is an interesting mechanism of action. So all of you are familiar with ESAs, erythropoiesis-stimulating agents, like epoetin alpha, darbepoetin. And this drug is actually erythroid maturation agent, EMA. So the luspatercept is TGF-beta trap. So it traps TGF-beta superfamily ligands and prevents activation of SMAD2/3 pathways. And by doing so, it allows improved or enhanced late-stage erythropoiesis. ESAs, like erythropoietins, they work at early phases of erythropoiesis, and I always wonder what happens when we combine the two, but this is not what this study was about. So this first study I'm just mentioning, Medalist trial, which led to the initial approval of luspatercept in the second-line setting. So this drug was certainly superior against placebo in patients who were refractory to ESAs or were not expected to respond to ESA because the patient's own erythropoietin level was high. So you can see that the primary endpoint was transfusion independence over 8-week period, which was accomplished in almost 38% of patients on luspatercept versus 13% of patients in placebo. The secondary endpoint was transfusion independent 12 weeks, also was better in patients who were treated with luspatercept. Luspatercept is an injection which patient has to get in the treatment center, and it is given once every 3 weeks. So now the most recent study of luspatercept was in the first-line setting. So I forgot to mention that the second-line setting was really specific subtype of MDS. It's MDS with ring sideroblasts. most of these patients will have SF3B1 mutation, which is the most common mutation in MDS affecting spliceosome. So in the first-line setting, the patients didn't have to be in this particular MDS subcategory. They were low-risk patients, and this is a randomized study against epoetin alpha, so the erythropoietin level had to be less than 500 because otherwise they would not be expected to respond to erythropoietin. So the primary endpoint was transfusion independence for 12 weeks, together with mean hemoglobin increase of 1.5, at least 1.5 grams per deciliter. So the primary endpoint was, of course, better in patients with who received treatments with luspatercept. You can see 60% versus 34%. And I just want to highlight a couple of subgroups where luspatercept can certainly did a lot better. It actually did better, in all of the subgroups. Of course, we cannot give you p-values because this study was not powered to do that. So, but you can see that when baseline erythropoietin level is more than 200, still less than 500, but more than 200, these patients do not do well on epoetin, on erythropoiesis stimulating agent. So also SF3B1 mutation, which is highlight of patients who have ring sideroblasts, this subgroup of patients continues to do quite well. And the difference between erythropoietin treated patients and luspatercept treated patients is quite significant there, 70 versus 32%. So based on these results, the drug was approved also in the first-line setting. And now you have to choose between erythropoietin, erythropoiesis stimulating agents, and this drug. And so it looks like it would be reasonable to give it to patients who have high erythropoietin level and who have SF3B1 mutation. So the next drug with interesting mechanism of action I'm going to talk about in low-risk MDS, which I already mentioned when I was talking about myelofibrosis. Same drug, imetelstat, it's telomerase inhibitor. So telomeres at the end of chromosomes protect chromosomes against damage and cells against apoptosis. And when cells divide, telomeres get shorter, so they need to be rebuilt. And telomerase is part of that mechanism of rebuilding the telomeres. So cells which are dividing faster than others, they lose telomeres with higher pace, and that applies to malignant cells. So the mechanism of action of this drug is to inhibit telomerase, not allowing rebuilding telomeres in this rapidly dividing cells, leading to the apoptosis. And so this study is called IMerge trial, is a phase 3 double-blind randomized study in the second line of for low-risk MDS patients. Again, randomization is against placebo. Imetelstat is intravenous administration every 4 weeks. And patients who were enrolled were those who were requiring a lot of transfusions, at least 4 units in the 8 weeks preceding to randomization. They also included patients who previously were treated with ESAs and stopped responding or didn't respond, or whose erythropoietin level was more than 500. So this is 2-to-1 randomization, 177 patients treated. And this is the longer-term results of the study, which were presented last year, and now the study is published in Lancet. So the primary endpoint was 8-week transfusion independence, and then secondary endpoint was 24-week transfusion independence. And you can see with the imetelstat, decent number of this heavily dependent on transfusions patients were able to accomplish transfusion independence. You have to understand that they were receiving at least 4 units in the 8-week period. So, and becoming transfusion independent in those circumstances are quite impressive. So I think this drug is certainly a reasonable option in second line for patients who are heavily transfusion dependent and have low risk MDS. So I'm moving to the last of big three, AML, and I'm not going to talk about all of those things on the slide. I just want to highlight that the part in red is where a lot of developments occurred since 2017. So the publication on 7+3, our iconic induction chemotherapy regimen for AML, was in 1973, very easy to remember. So, but since that time, not much happened until 2017. Where a lot of drugs, including a lot of targeted therapies, started to be approved. And 11 drugs were approved in AML since 2017. Some of them have more than one approval, so that's why a lot more boxes there, but total of 11 drugs. And I'm going to talk about 12th drug, which is likely to be approved before the end of the year. So this drug is a menin inhibitor, revumenib. So apparently, the menin is very important to regulate activation of HOX and MACE genes transcription, and that leads to uncontrolled proliferation. And so menin does that when it combines with KMT2A, rearranged KMT2A oncoprotein. So there are many partners with KMT2A, and this is also the KMT2A gene used to be known as multilineage leukemia gene because the rearrangements may lead not only to AML but also to ALL. And, so the revumenib blocks the pocket to which KMT2A attaches and shuts off transcription of HOX and MACE, leading to differentiation of malignant cells and natural apoptosis. So this study, Augment 101, was presented last ASH, as well as was just published in August in JCO. So the part of the study which was published was about KMT2A rearranged acute leukemias. Most of the patients had AML, some had ALL, and there were a few pediatric patients. So the part of the study which is ongoing is for NPM1 mutated AML patients, which is more common subtype of acute myeloid leukemia. So the primary endpoint was complete response and complete response with incomplete hematological recovery. This is phase 1, phase 2 registration trial, and based on this study, the drug is currently undergoing process of approval in the FDA. So the patients who were enrolled were quite difficult to manage. First of all, KMT2A rearranged AML is difficult to disease to treat. It's very challenging to get these patients to remission, and if you get them there, they frequently relapse. So most of these patients, actually, more than 40%, received at least 3 lines of previous therapies. You can see this here. So venetoclax combinations were given to more than 65% of patients, and this safety population and efficacy population. These are not comparison groups. So, and then a lot of patients, more than 40%, were already transplanted and relapsed after the transplant. So certainly very heavily pretreated population. So this is the primary endpoint of the study, CR plus CRh. This response was accomplished in 23% of the patients. So overall response rate was a little high, 63%. So, but the p-value there was generated by expected response in this patient population from other treatments currently available, and this is about 10%. So the other thing to highlight here is that CR rate was 18%. So it's not, the highest, but nevertheless, in this heavily pretreated patients who have pretty bad acute myeloid leukemia, it is pretty decent accomplishment. Median duration of response in those who accomplished CR and CRh was 6.4 months, allowing some of these patients to get to transplant. And as you can see, 14 out of 36 patients who responded went to transplant. So this drug has few interesting side effects. First of all, cytopenias, which are common for medications we're using for management of AML. So, but then there is differentiation syndrome. You saw from the mechanism of action how this may occur, and QTc prolongation. No patients stopped the treatment due to one of these side effects of interest. And, obviously there are some GI side effects, including nausea, diarrhea, and vomiting. So overall, the drug is reasonably tolerated in this group of patients, and we're looking forward to add 12th drug to that list we have since 2017 for AML management. I wanted to finish with the slide to highlight the studies which Yale participated in. And first of all, rusfertide, hepcidin mimetic, new class of drugs for management of PVR. We didn't participate in the study I presented, but we were involved in another one. So is asciminib, the STAMP inhibitor, which is awaiting approval in the first-line setting for chronic myeloid leukemia. Again, we participate in a different study with this medication. So finally, in myelofibrosis, we have more connections. Pelabresib plus ruxolitinib MANIFEST-2 trial was opened at Yale. It's finished accrual, but we're still following the patient on that study. And selinexor plus ruxolitinib is the study which opened and available for our patients in frontline setting. So we are waiting to open imetelstat plus imetelstat study in the second beyond line for myelofibrosis, and I'm hoping it will be opened in about 4 weeks. So looking at low-risk patients with MDS, our group participated in the development of luspatercept and imetelstat under the leadership of our Chief of Division of Hematology, Dr. Amar Zaidan, who presented this data at ASCO last year. Finally, acute leukemia, acute myeloid leukemia patients hopefully will soon benefit from the approval of menin inhibitor revumenib. And I presented the data, which was published in JCO last month. We're involved in the development of another menin inhibitor. In fact, there are 5 of them being developed at the same time. Revumenib is just up front. So the drug which we are developing at Yale is ziftomenib, and we have trials combining this medication in the frontline and beyond settings with chemotherapy and low-intensity treatment, as well as other targeted therapies. And I'll finish here. Thank you.
So it is 3. In the interest of time, first off, let's actually open up to the floor, I think, if there's questions, but let's bring the panel up. And, the other thing is, this was incredibly comprehensive in heme malignancy, well over 100 different malignancies. And you can see that the amount of development, amount of new drugs, and just how complex. And so tying on to the previous talk, AI, clinical decision support tools, and frankly, more specialized heme malignancy care is going to be really needed. So if there are any questions, are there? Yeah, okay. So we'll go ahead and I do think we should talk about cellular therapy. So we really didn't touch on that in these kind of drug-focused development abstracts. And so this case will kind of cover both CAR T and transplant. This is someone that I met many years ago. He was 59 at the time. He presented to the emergency room. He had adenopathy and had an ultrasound showing DVT in the left leg, as well as a CT scan really just showing bulky, extensive adenopathy. A core needle biopsy later that day, was discharged home to follow up, and the biopsy came back as diffuse large B-cell lymphoma, most common of our non-Hodgkin lymphomas. And we do still use IHC to classify. We have a long way to go to further classify DLBCL in terms of gene mutation analysis, but this was a non-GC subtype by Hans algorithm CD10 negative. Importantly, this was a non-double hit, so he did not have BCL2, BCL6, or MYC. And his staging PET-CT, you can see here, bulky adenopathy, mostly in the abdomen, a little bit above the diaphragm, perhaps spotty bone marrow involvement, but no significant extranodal disease. And his IPI score was actually quite low, so 2, elevated LDH in advanced stage, and based off of very simplistic prognostic modeling, would have a good predicted survival and PFS with R-CHOP alone. So that patient did get R-CHOP, and we'll go over his case a little bit. But these days, we've really shifted away towards pola R-CHP, particularly for the non-GC subtype or activated B cell. And why is that? You can see here 27% reduction in hazard for progression. With really, this was a double-blind study, very minimal change in toxicity compared to R-CHOP. So you get a PFS benefit, really no significant change in neurotoxicity, no significant change in cytopenias. And so most of the field has adopted this over R-CHOP. And this was about the 10th study of trying to beat R-CHOP in large randomized studies, finally for a positive study. As Dr. Sethi noted, we do have the GlowFit pola R-CHP study, which is really important, next phase of first-line DLBCL. So unfortunately, this was a patient in 2019. Our best therapy at the time was R-CHOP, got 6 cycles, and actually stayed in remission until about 30 months when he presented with recurrent lymphadenopathy. Had a biopsy confirming DLBCL, and because this relapse was well over a year, went on to get salvage chemo in a RICE, salvage chemo, CR, and then beam auto. Unfortunately, within 8 months of the transplant, developed, again, recurrent adenopathy. And the question really for us at that time was, how do we approach third-line DLBCL? Dr. Isufi, do you want to talk a little bit through, this was a patient we shared in terms of third-line options for DLBCL?
Sure. So historically, outcome has been extremely poor in this patient population with less than 10% 6-month overall survival. So we're very fortunate to have this treatment landscape now with multiple new approvals just in the last 5 years. So we have several classes of agents. We have antibodies targeting, glycoengineered antibodies targeting CD19. We have antibody drug conjugates that also target CD19 and also CD79B. And more recently, just last year, a whole new class of bispecific antibodies where we have 2 agents that have been approved for third-line setting for relapsed refractory diffuse large B-cell lymphoma, and then finally also a nuclear export inhibitor. So as you can imagine, while this is all good, it's become increasingly difficult for us to figure out how to best sequence these therapies, particularly since the approvals of CAR T-cell therapy initially in the 3rd line, but now also in the 2nd line setting. And these agents have really extended survival, which has increased the complexity of management of these patients in our clinics.
Yeah, and I will add, certainly CAR T has been a dramatic improvement over previous options, but still an unmet need. So, about 30 to 40% of patients will have long-term cure with CD19. And so there's a lot of active investigations. You can see here we have additional CAR T targeting CD22. There's bispecific CAR Ts combining bispecific engagers in clinical trials, trispecific, as well as several targeted small molecules that we have open for these complex patients. So this patient did, in fact, get CAR T, went into a CR, and unfortunately developed, again, recurrent FDG-avid lymphadenopathy about 6 months. So this is a patient that was predicted to have a good outcome, IPI score of 2, received standard of care therapy, and despite that has relapsed again. His biopsy importantly confirms his CD19 expression remained. So this is a patient that, again, we shared with Dr. Isufi, and given the prior response to chemotherapy and non-chemo refractoriness, we developed and decided to go along and give more chemotherapy with Pola-BR. This patient did have a CR and is currently in a CR after an allo transplant. But the takeaway really is that primary refractory and relapsed DLBCL really complex. We have lots of treatment options, really all approved off of single-arm studies. In early referral of patients you think might be progressing or have clearly progressed is really key because of the barriers to, say, bispecifics and CAR T that are quite complex. The other thing is, this is a patient that, again, we predicted was going to have a good outcome, but really the last 5 months, or 5 years rather, have really been dedicated to fighting his cancer. And so improving the first-line cure is really key, I think, to improving quality of life and survival with DLBCL. So again, first-line studies are open, and please refer your patients. I think we have time for one more case. I do want to talk about BALL because we didn't talk about that. So this is a patient that we've all shared who's 47. He presented to urgent care and had really minor symptoms, but on blood work had concerns, had blasts, had leukocytosis, anemia, and thrombocytopenia. He was sent to the emergency room. He was admitted, and here he was diagnosed with a B-cell ALL. He had a bone marrow biopsy. The vast majority of his marrow was effaced by BALL, and this was a pH-negative disease. So Nikolai, can you just talk a little bit about what's the current management of pH-negative ALL?
The exciting development this year in June, approval of blinatumomab in consolidation treatment in the frontline therapy of patients with pH-negative B-cell ALL. The drug was initially approved in the relapsed refractory setting, then for patients who have positive measurable residual disease. And now, based on E1910 study, which was just published in July in New England Journal of Medicine, It got approval in consolidation, frontline treatment consolidation, patients with MRD, measurable residual disease, negative ALL after initial treatment. So you can see the schema on the left. So the MRD measurement happens after intensification, and then patients were randomized to blinatumomab and chemotherapy, or just chemotherapy alone. So before they would proceed to maintenance. And when they were randomized to blinatumomab, they received 4 cycles of blinatumomab, which were spread out and between the received chemotherapy. So this group actually benefited from better survival, and you can see the survival curve on the right. So the 3-year survival overall survival for patients on blinatumomab arm was about 85%. For chemotherapy only was, I think, around 67%. So, and that is significant difference, and that's what led to the approval of this drug in June.
And Dr. Gowda, can you just talk a little bit about, who we are giving allotransplants? This was a very common indication for allotransplant. Has the blinatumomab consolidation changed your thinking?
So that's actually an interesting question. The trial that Nikolai mentioned did not say don't do an allotransplant. So if you want to do an allotransplant, it's not excluded. So that's my bias as a card-carrying member of the transplant group. But should blinatumomab be used? I think it certainly is going to change the landscape the way it is come in. One way to interpret this study is to say, if you want to go on a 3.5 years of continuous therapy, listen to Nikolai. If you want to do maybe a few rounds of blina and then you want to cure after that, come talk to us. We'll both have a tumor board and discuss about it. If you're in a pediatric group, I still think a lot of colleagues are contemplating that. Is one and done a better option than a 3.5 years of therapy? It's an ongoing discussion, but I'll keep that going with Nikolai later.
Yeah, this is really nice. So step 4, one little box of maintenance is really 2 years or 2.5 years. So
yeah, it's actually in blinatumomab, it's counted from the beginning of intensification. So it's actually, with blinatumomab, it's much less, because blinatumomab 4 cycles, each cycle is 6 weeks. So it's less than by 24 weeks, the maintenance. So the treatment in 2 arms was the same duration.
So despite this patient getting, novel standard of care therapy with chemotherapy backbone and blinatumomab, unfortunately, he had really progressive disease early on the blinatumomab. Again, biopsying and improving the continued expression of these antigens that we have so many good therapies for is important. So he had a biopsy showing CD19 as well as CD22 positivity. And much like the multiple myeloma, where we're adding great therapies up front in that first relapse becomes that much more difficult. How are we, handling these patients that have received chemo plus blinatumomab in the first-line setting?
So so obviously at 3 years on this E1910 trial, progression-free survival was about 80%. So that means 20% either died or progressed. So those who progress, they have options. And again, we benefited from a lot of drug development and B-cell ALL, and that includes inotuzumab ozogamicin. We participated in INNOVATE trial, the phase 3 study comparing this antibody drug conjugate against CD22 antigen, which is present in about 80 to 90% of patients with B-cell ALL. And as you can see, the standard of care arm included, garden variety chemotherapy, including high-dose cytarabine, FLAG, etoposide, and metoxantron. And, the survival was better on inotuzumab arm. Still, for this relapse refractory patients, the survival in inotuzumab arm, median survival was, I think, was 7.6 months. So it was a lot less than a year. I think it was 6.7 for chemotherapy and 7.7 for inotuzumab. Still not perfect. And the other problem with inotuzumab is hepatotoxicity. So the only way to cure a patient with relapsed refractory ALL, I have to say younger patients can probably be cured with CAR T-cell therapy. But for the older patient like this one, I believe it's transplant. And Lohith may have a different opinion on that, but he's a transplanter. So I hope he'll agree that transplant is the way to go for someone who is in his late 40s. So inotuzumab is a bridge in my mind. And the problem is if you use it, then the risk of hepatotoxicity with transplant may be higher. And this is veno-occlusive disease. We lost one of my patients who was enrolled on that study and received inotuzumab to veno-occlusive disease 30 days after he was transplanted. So you have to use this understanding what is down the road. And, you know, so I think it's a great drug. Response rate is 80%, and MRD negative response is 80%. So you can get these patients to respond, but obviously it doesn't last looking at this curve. So this would be a bridge to transplant. So we try not to give more than 2 cycles if patient is going to transplant. We try to give transplant at least 2 months after the last cycle.
And maybe Dr. Gowda can just comment on, you know, if a patient gets, say, CD22, gets CAR T, is that a definitive therapy, or are we often taking those patients to allo as well?
I think I largely agree with what Nikolai said. I just want to pinpoint what he missed out. If you give inotuzumab and a second salvage or beyond, the survival rate is about 10%. 2017, it led to inotuzumab. 2018 was Blina. That was a time when you were comparing against a garden line chemotherapy, which was pretty crappy. After that, then came the CAR T cell therapy. The response rates were high. I think the median overall survival then was about 18 months. Median duration of response was greater than a year, which is significantly better compared to ENAR Blina. Not to forget, these patients had already received ENAR blinatumomab. So despite those drugs, CAR T cells seem to be showing favorable efficacy in that. But I think you ask a very pointed question, should allotransplant be done for these patients? I don't think there is any prospective data to say that. Obviously, age is one of the significant variables in ALL management. And even in the Blina study that he showed that age greater than 55, the confidence interval crossed once. So I would argue the efficacy of that there. But having said that, the CAR T protocol that you've shown here is a significant achievement to the extent that historically adult patients did pretty poorly. Now, even in this trial, it seems like the allo-HCT may not be benefiting too much after a CAR T, but then again, it's biased to the extent that who is going to allo, who is not going to allo is kind of gamed differently. So I would interpret that data with caution. It needs to be evaluated both by the transplant and the non-transplant team before we make a mind on that. Thank you.
Great. Dr. Silber, sure.
I just wanted to add that as unfortunate as this patient was to relapse, he's still fortunate in that he still has CD19 and CD22 expression because lack of CD19 portends for a very poor outcome and lack of response to CAR T cell therapy. And so I think we have to keep that in mind when we use antibodies, antibody drug conjugates, bispecifics that actually deplete the target of CAR T. And the other thing that I wanted to mention is that how are we measuring the status of these antigens is also important. We often rely on flow cytometry, but the cutoffs for positivity are not entirely clear. And I think the field is going to move toward measuring antigen density, and we're not doing that routinely in clinical practice.
So plenty of opportunity. I think with that, I wanted to thank my group, and this will conclude the malignant hematology section. And I'd like to invite Maryam Lustberg, who joined us several years ago from Ohio State, who will be chairing the breast session. Thanks so much. Sorry about that. Sorry, I'm late. Sorry.
Awesome. All right. Thank you for sticking around for the best session, which is the breast session. And thank you again to all the sponsors for making this possible. We're really glad to have conversations with you throughout the day. So as breast cancer goes, there's always a lot of studies and a lot of updates. So I am sure that I have left out your favorite study in the last year. So apologies in advance for that, but 15 minutes is a short amount of time. So I wanted to give you a few highlights in metastatic breast cancer, and then we'll wrap up with early stage. So as a historical context, I thought it would be worthwhile to just remember that 26 years ago this week was when Herceptin or trastuzumab was first approved in metastatic breast cancer. And I think it's the history of HER2-directed therapy is indeed a history of innovation, discovery, and personalized medicine. And I think our patients have certainly benefited through all the scientific discoveries that have made these drugs possible. And so starting out with Destiny Breast 12, which was presented just in ESMO a week and a half ago. This study was a phase 3, phase 4 open label study asking the question about the activity of TDXD, a HER2 ADC that all of you are familiar with, in patients who had brain metastases or no history of brain metastases. But it's the largest study using this particular agent to see what activity there was in the CNS. And these patients all had metastatic HER2 positive disease. Most of them were within 2 lines of prior systemic therapy, no prior to tucatinib. And the results were remarkable in that the 12-month progression-free survival was at 62%. And in patients who had baseline brain mets, as you can see in the bottom plot, quite remarkable activity in the brain with 62% responses in patients with active bone metastases and just remarkable CNS activity. There was certainly interstitial lung disease that was noted, as you can see, as we have seen with other studies with trastuzumab deruxtecan, including 6, unfortunately, grade 5 events. However, I think the importance of Destiny 12 is that we finally have the largest study showing the activity of TDXD in with intracranial activity, and this I think firmly plants TDXD in that second line setting till we have additional first line data in Destiny 09, which is expected later in the year. Currently, we also have a tucatinib-based regimens based on HER2 climb data as well, but based on the strong systemic therapy activity of TDXD, both in the brain and the body, I think most of us will be using this agent firmly in the second line setting. So I wanted to present Destiny 06, which was presented in this year's past ASCO and discussed by Ian Kropp as well. And this was a phase 3 study taking patients who were chemotherapy naive in the metastatic breast cancer setting with hormone receptor positive HER2 low or HER2 ultra low. I'll show you the definition of HER2 ultra low in the next slide. And they had either 2 lines of prior endocrine therapy or 1 line in the metastatic breast cancer setting and had progressed very quickly in their adjuvant endocrine therapy regimen. And they were randomized to TDXD versus standard chemotherapy regimens. Many patients actually ended up receiving oral capecitabine as their standard of care treatment arm. HER2 definitions, as we have learned from David Rim in Yale, are quite problematic. IHC can be very challenging to do. Here, ultra low is defined as faint membrane staining in less than 10% of the tumor cells, compared to an IHC of 0, where there's actually no membrane staining. And again, we're seeing remarkable activity of TDXD with a median progression-free survival of 13 months compared to 8 months in the standard chemo arm. And this is the overall survival data are still premature, and many patients in the standard of care arm ended up going on to receive TDXD as their next line of therapy. So we'll await maturity of these data in terms of overall survival advantage. And in kind of looking at exploratory analysis of this ultra low population, we're seeing that PFS improvement in the HER2 ultra low population consistent with the results that we're seeing in HER2 low. So does this change our practice, or do we need more data? And where should T-DXd be used in HER2 low disease? We have other ADCs that have been approved and available, including sacituzumab based on TROPiCS-02. And I think this is continuing to be an evolving story of how we sequence our T-DXds. In general, most of us as breast oncologists are not jumping to use T-DXd in the first line setting, except in select cases with high visceral burden with rapidly progressive disease. Whether we're actually going to include ultra low categorization and pathology reports is also under discussion right now. We know that, as I mentioned before, IHC categorization is prone to a lot of bias and errors, and so we need better quantification. And the problem of ILD toxicity continues with 3 deaths reported in DESTINY-06. I think it does make us really question which patients are really the right candidate for this therapy versus perhaps safer systemic therapies first. We have a investigator-initiated study here looking specifically at HER2 IHC 0 tumors. My team members are here, including Dr. Khan and Dr. Kropp, and this will be sponsored by AstraZeneca and Daiichi, and we're specifically going to be focusing on tumors with IHC of 0 and evaluating and quantifying the HER2 signal in David Rim's laboratories and looking at associations with response. Lots of interesting correlatives to come out of this study. Lots of combination strategies and studies are underway with ADCs. As you can see, multiple strategies are being looked at, including immunotherapy combinations. The SASI-IO trial was presented in last year's ASCO, and in this particular study, there was no significant improvement with the addition of pembrolizumab to SASI, but lots of interesting correlatives to kind of stem from this combination. Lots of other studies are continuing to look at immunotherapy combinations with ADCs, including TROPION-05, which we have open here as a first-line option for PD-L1 tumors, where patients can be randomized to Dato-DXd plus Durva versus the traditional KEYNOTE-355 backbone chemo and pembro versus Dato-DXd alone. The sequencing of ADCs continues to be one of the huge debated topics in breast cancer. We know that whatever ADC you start out with, the second ADC tends to have a lesser prolonged response. So the TRADE-DXd study, which is part of the Translational Breast Cancer Consortium, which we will have open here, will be one of the studies that will prospectively evaluate questions related to the sequencing of ADCs. Multiple ADCs with novel targets are in development in breast cancer and beyond, as you all know. And there are multiple combinational differences that are under development, including changing the payload. And this particular agent is generating quite a bit of excitement, BB1701. We have the study here with Dr. Khan as the PI. The HER2 antibody target is attached to a unique linker, with eribulin being the actual payload. As you can see here, the dose optimization cohort has completed accrual, and dose expansion will be open soon. So moving on to specific targeted therapies in hormone receptor positive breast cancer, really the knowing your available targeted therapy options is absolutely the message that we want to share with all of you as you're seeing these patients. Patients need to have a real-time evaluation of their ESR1 status, which is an acquired alteration, as you know. And when they do not have any identifiable alterations, the options include potentially using another endocrine therapy partner with other targeted therapies, such as another CDK4/6 inhibitor or everolimus. Out of this year's ASCO, there was some excitement about the post-MONARCH study, which took patients who had had prior CDK4/6 inhibitor, and they went on to receive a second CDK4/6 inhibitor, which was abemaciclib. And several other studies have also looked at the question of sequencing CDK4/6 inhibitor. The post-MONARCH data are here. I won't spend too much time on it, but really modest increases in progression-free survival when we're sequencing CDK4/6 inhibitors. Patients who are more than 12 months prior in their endocrine therapy response and not a lot of disease burden tend to be the ones to benefit the most. And most of these patients previously received palbociclib. So as our practice has changed to not necessarily choose palbociclib as our first line and targeted therapy agents, the utility of these data and how applicable they are remains to be determined. Wanted to emphasize that TBCRC048 was presented in ASCO as well, emphasizing the importance of knowing the somatic BRCA 1 or 2 alterations within breast tumors, remarkable responses with just single agent PARP inhibitor in this population, as well as in germline PALB2. Wanted to tell you about a new targeted therapy that was just approved in breast cancer in May of 2024 in INAVO 120 study, specifically a triple targeted therapy option with a PIK3 inhibitor plus palbociclib as well as fulvestrant. And we have Capitello 292, similar idea with capivasertib with fulvestrant and a CDK4/6 inhibitor. Rushing through the early stage breast cancer, we have a recent approval on September 17 of adjuvant ribociclib, which joins adjuvant abemaciclib for early high-risk breast cancer. The 4-year study results of the NATALY trial were presented in ESMO just a few weeks ago. And the most important takeaway is that even after the conclusion of the 3-year study intervention period, the curves are continuing to separate with a delta of about approximately 4 to 5%, both in stage 2 and stage 3 breast cancer. And we're continuing to see this difference in even node-negative disease. So this was the basis for the FDA approval of ribociclib. For reference, the NATALY population included more lower risk disease, and this chart nicely compares kind of which stage 2 breast cancer tumors were actually included in the NATALY, which is a higher risk population, higher genomic risk, higher Ki-67, and higher grade. We have a wonderful investigator-initiated trial here with PIs from Dr. Weiner and Dr. Jing Du, one of our newer faculty. And the question of, does every high anatomic risk, low genomic risk breast tumor truly need chemotherapy? And this question is something we debate every week in conference. And in this study, we wanted to be innovative and patient-centered, and our patients get to choose which arm they actually are going to enter. And our hypothesis is that, prior chemotherapy may make patients more likely to have discontinuations and dose modifications in the CDK4/6 inhibitor. This is funded by the Breast Cancer Research Foundation and is under consideration for funding by Novartis. Wanted to just wrap up with sharing with you final results of KEYNOTE-522, which is a regimen we're actively using for our high-risk triple-negative breast cancer. These updated overall survival results again reaffirm that this highly tough but effective regimen is something that is associated with improved overall survival, both in patients who have achieved a PCR as well as not, as this curve can say. Only 65% of patients actually achieve a complete pathologic response with this multi-agent chemoimmunotherapy regimen, and additional options are needed. So lots of studies are looking at newer ADC immunotherapy combinations, including Tropion-Breast04 here with Dato-DXd and Darva, which we have open here. And when patients do have residual disease, we absolutely need newer novel therapeutics beyond the standard adjuvant capecitabine of CREATE-X. So TROPION-Breast03 is open here, where patients can be randomized to receiving Dato-DXd alone or in combination with durva. If patients achieve a PCR, we are also participating in the Alliance study, where if they have achieved a PCR, they may be randomized to observation instead of continuing on adjuvant pembro. I'll wrap up by saying that we have lots of trials in our portfolio, including multiple investigator-initiated trials that are in development. I do want to do a shout out to Dr. Rosenblatt, who has a number of investigator-initiated trials, including a new trial that will be opening soon on minimal residual disease through the Translational Breast Cancer Consortium. We are continuing to focus on really each indication and each subtype of breast cancer and looking for innovative trials that we can offer our patients. With that, I want to invite the panel up. We have 3 cases to present to you, and we will make sure to, if my colleagues can come up, we'll bring up their slides. I think there's one file.
Which one?
It's there's a combined file. I guess it didn't make it. Okay, why don't we, the combined file didn't make it through. We'll start with your presentation if it's okay. Do you want to start? Sure, we'll have Dr. Evans start first. Okay, all right. All right, we'll make it great.
Yeah, we'll be fine. So we're going to talk a little bit. We're going to do a quick case-based presentation. I apologize for running through my slides. Who here does Peloton? Anyone? Woo! All right. So anyone know which slide I'm going to show, right? We have our Peloton instructor with breast cancer. She makes a great case. So she lives in the UK. So we have a 35-year-old woman who presents with a palpable mass. Biopsy shows a triple positive, HER2 positive breast cancer. Imaging shows negative nodes and a T1C tumor. She receives 12 weeks of neoadjuvant TH chemotherapy, followed by lumpectomy and sentinel lymph node biopsy, revealing a path CR. Her values are long-term disease-free survival, cosmetic outcome, and staying physically active in her job. What is the most appropriate course of whole breast radiation? So we have 2850 centigrade and 5 once-a-week fractions plus boost. We have 5,000 centigrade and 25 daily fractions plus boost. 4,005 and 15 fractions plus boost, or 2,600 centigrade and 5 daily fractions plus or minus boost. So I know you guys are all medical oncologists and you just are dying to answer that question, but I will tell you that my answer would be 4,005 centigrade plus boost. What she received in the UK was fast forward plus boost. And we're going to talk about why I think that maybe wasn't the best choice, and had a lovely quick conversation during the break with my colleagues at MD Anderson and Johns Hopkins and Ohio, who also would not have treated her that way. So let's talk about who we do use ultra hypofrac for and what the indications are. So, you know, things are more complicated now than when I started training. You know, it used to be everybody got 6.5 weeks of radiation, 6.5 weeks of radiation. That's conventional fractionation. And then starting around 2010, 2012, we started getting good information from the Canadians and the UK groups that moderate hypofractionation, doing about a 4-week course of whole breast radiation, was just as effective oncologically and also more favorable for cosmetic outcomes as well as fatigue, pruritus, et cetera. And now we're starting to get information about ultra hypofractionation. Hypo, few, fractions, number of treatments. And so there are 2 different regimens out there. There is either the fast treatment, which, as Dr. Herbst brought to our attention, is like a throwback to split course radiation therapy because it's once-a-week radiation therapy. We don't do that. But this trial looks at that. And then the other is cutely named fast forward because it's all in 1 week. And that makes much more biologic sense. All right. So currently, the indications for conventional fractionation often is in the setting of regional nodal radiation or reconstruction. We're starting to get exciting data, the fabric data, and some others looking at deep flaps as well, that perhaps those are safe. We're a little, all sort of anxious about, making sure that the brachial plexus does well with the larger fraction size of the moderate hypofrac. So we're starting to get some indications that maybe we can move away from conventional fractionation in the post-mastectomy set, but still not quite there yet. And then ultra-hypofractionation, what should we look at? So let's briefly talk about the data, and I'm committing myself to finishing by like 3:43. This trial looked at 915 women and assigned them to the old standard, 5,000 centigrade. Remember, that has worse cosmetic outcomes than moderate hypofrac, so a more generous comparator. It only has to be as good as what's not considered to be as good today. And 5 fractions once a week. No one was allowed to have boost. And their secondary outcome was local regional recurrence. So they did meet that secondary outcome. Very excellent results. And this is at 10 years, looking at 1 and 1.2%. And we do see a very interesting thing. So the 30 gray arm, right, which is 1.5 gray more than the 28 gray arm, actually saw more photographic change in the breast. So even just with that small difference in fractionation, it was close to double the amount of mild or marked findings in terms of cosmetic changes in the breast. And then when we look at breast shrinkage, there was no statistically significant difference between the 28.5 gray and the 50 gray, but it was worse for 30 gray. Also giving us pause when we think about the fact that none of these patients got boost. And so I am very cautious about considering adding boost when a 1.5 gray change can cause quite a difference in cosmetic outcome, depending on the values of the patient. And then looking at in duration, we actually did see that there was a difference even from the 28.5 gray to the 50 gray with more in duration. Thankfully, it's a small number. It's about 1% versus 2%. And then looking at breast edema, we see a trend towards more breast edema with the 28.5 gray versus the 50 gray. So other effects pretty comparable to what we would expect otherwise. Not much exciting there. Did have a decent amount of people referred for lymphedema, about 13.4%, which, in our own data could be quite realistic. So the conclusions from FAST, that there may be some difference in edema, and there was more breast in duration, but not really a strong difference in photographic breast appearance. So fast forward was looking at a little bit different population. So it allowed up to T1 to T3, N0 to N1 breast cancer. Previous chemotherapy was permitted, but not concurrent chemotherapy. They had a much lower rate. The other study had 71% of their patients enrolled in photographic assessment. This only had 76 and had 4,000 women. So they were either the standard in this was 4,005 and 15 plus or minus boost. And so that's the better cosmetic outcome comparator. And it was either 27 gray in 5 fractions or 26 gray in 5 fractions. Again, slicing the hairs very fine in terms of our dosing. So, you might be saying, how is this different? Why does this matter, right? What's the big deal? So we talked about the comparator being better in fast forward. Fast forward is all done in 1 week, not 5 days a week, so not split course. Fast forward had about 25% of their patients receiving boost. The dosing is a little bit different. And in fast forward, the primary endpoint was actually ipsilateral breast tumor recurrence. So, why are we able to lower the dose a little bit more when we're not spacing the treatments out by a week? Again, we think about sort of the 4 Rs. There's a chance for repopulation, right, when you're only giving radiation once a week, and perhaps that's why fast The FAST is using a slightly higher doses to compensate for that. And by putting it all in 1 week, we still allow enough time for repair, but yet we're allowed to use a little bit lower dose and hopefully have less toxicity. So the entry criteria sound really broad, but only 1 to 2% of the patients in Fast Forward were under the age of 40. And we know that young age is certainly correlated with risk of recurrence. So again, that's why I'm not recommending it in part to our 35-year-olds. Pathologic tumor size, although they allowed T3, median tumor size was 1.6 centimeters. 81% of these patients had negative nodes. And about 60% of them were low risk. So when we look at boost, again, about a quarter of boost, most of them were 10 gray and 5 fractions, which they're doubling the time. All right, so I'm already over my time that I promised that I'd use, so I'm going to ship through and talk about our conclusions here. So, basically 2,700 centigrade and 5 fractions lost to 2,600 centigrade in every single time. It was equivalent in terms of cancer outcomes, but they found more edema in the 2,600 centigrade versus the standard 4,005, but still low volume, 2.5 versus 1.5, more breast induration with 2,600 than 4,005, more telangiectasia. And they looked in women for moderate or marked adverse events in the chest wall. And the one thing that came out as significant was age less than 50. So all reasons why when we think about ultra hypofrac for our women, we tend to do it in a population that's favorable risk over the age of 60. The Fast Forward has sort of the better data in terms of the strength of the data, what the comparator is used for. That's only 5-year data right now, done predominantly in a low-risk population. So that's who we're using in. Classically, ER-positive women over the age of 60 who are willing to accept a little bit more fibrosis, induration, edema in exchange for being done in a week. Thank you.
So we'll move on to our surgical case. Good. Dr. Ellie Proussaloglou is one of our newest breast surgical faculty within the breast division, seeing patients in both New Haven as well as Lawrence and Memorial.
No problem. I can go without slides if we need to, but it'll be nicer to see some graphs instead of me trying to visually describe them. While that is perfect, that's great. Thank you. So I just wanted to acknowledge my colleague, Dr. Berger, helped put together the lion's share of these slides. In the interest of time, we're going to really run through and kind of skip a lot of the background. And so she kindly allowed me to present, but thank you, Elizabeth. So we have no disclosures. The key question here is how do we appropriately manage the axilla in different clinical situations? And my bias, our bias as surgeons, is that we see patients routinely post-operatively for whom we think we've done a really beautiful axillary surgery, and we see their pain, their seromas, their challenges with radiation. And so we're really fortunate that we have really good historical data as well as more modern trials to help us answer how can we thoughtfully de-escalate axillary surgery without worse outcomes. As you know, breast cancer surgery used to be extremely barbaric. Radical mastectomies were the standard. And nowadays, over many clinical, pivotal clinical trials, we have thoughtfully de-escalated care to do smaller breast surgeries and smaller axillary surgeries with improved or equivalent outcomes. The sentinel lymph node was first used for breast cancer in 1994, so about 30 years ago. And it really hinged on these studies that showed us that the false negative rate of doing a good sentinel lymph node biopsy for breast cancer, ideally with dual tracer, was less than 10%, so at an appropriate threshold. So much of our cancer care for clinically node negative women transitioned to axillary, instead of axillary dissection, to doing sentinel lymph node biopsies. You probably remember this from your medical school rotation. We inject dye and find lymph nodes in the axilla. And The clinical case that really came to mind when I was thinking about how do we think about de-escalation of the axilla from a very basic level is a patient Dr. Khan and I share. She's a 33-year-old patient, self-palpated a mass, had about a 1.5 centimeter invasive ductal cancer with some DCIS, negative margins, clinically node negative on exam, and axillary ultrasound preoperatively was negative, as was MRI. Her final pathology had 4 sentinel nodes, 1 with a macrometastasis, 1 with micrometastatic disease, 2 negative. Because of the Z11 trial, we spared her the morbidity of an axillary dissection. Z11 asked, in women with small volume disease in their axilla, 1 or 2 nodes that are positive, is there a benefit to axillary dissection if they're getting radiation therapy alone? And thankfully, we found that in patients that are clinically node negative, sentinel lymph node biopsy in that setting and adjuvant radiation with a boost is appropriate. In patients who obviously present with additional disease or meet criteria for N1 disease on pathology, we do recommend an axillary dissection. The NCCN guidelines have been updated to reflect that if there's 1 node that has been biopsy proven preoperatively and the rest of the axilla appears normal on exam and imaging, and then again, we have only up to 2 abnormal nodes on final pathology, we can continue with a sentinel lymph node biopsy without introducing axillary dissection, thereby minimizing risk of lymphedema and pain and complications. The SOUND trial is one of the most recently published trials and where I'll focus much of our energy today. So the clinical case that comes to mind here is a patient that I actually saw in clinic today. Now having done this work and having published, I wish that we might have made a different decision for her. So she had a small image detected 1.5 centimeter tumor. She had an axillary ultrasound that was negative. She had benign pathology results, negative margins, small tumor. Ultimately, she mapped very well. 6 lymph nodes came out, all negative. Great news. She comes today and she has a large palpable seroma sort of filling her entire axilla. She tells me it felt like there was an egg there and it started to pop, and now all of that fluid is in her soft tissue. She's doing well, she's optimistic, but this SOUND trial could have perhaps spared her some of that morbidity. It asked the question, in clinically node negative women, ideally with small tumors, and with a negative preoperative ultrasound, can we spare sentinel lymph node biopsy? Can we just avoid doing that whatsoever? Median age was 60, my patient was 63, and most women were postmenopausal with ER-positive disease. JAMA Oncology has this really beautiful summary table, so I pulled it in here instead of recreating the wheel. Nearly 1,500 women were analyzed, and the finding was that omission of sentinel lymph node biopsy was non-inferior to sentinel node biopsy in this patient population. Of note, the patient population in SOUND had a wide range of ages, had a wide range of tumor biology, though 92% were ER positive, and a wide range in terms of whether adjuvant radiation therapy was used. So these results stand true based on individual adjuvant decision-making. Now, of course, we're learning more. This was recently published in 2023, but certainly helps indicate that perhaps for some women with small disease, negative exam, and negative axillary ultrasound, we can spare them morbidity in total. And so this just breaks down some more of the details. So they had both primary and secondary outcomes. Axillary recurrence was 0.4% in both settings, regardless of adjuvant treatment decision. In the neoadjuvant setting, we could talk for 2 hours about this. We had many trials that looked to figure out, can we appropriately find low false negative rates after neoadjuvant treatment? And ultimately, we had several studies that indicated that the rates of nodal PCR were very high after neoadjuvant chemotherapy. So we asked, can we appropriately de-escalate surgery? ACOZOG Z1071, as well as several other trials, found that if we use dual tracer and appropriately remove 3 or more lymph nodes at the time of surgery after neoadjuvant chemotherapy, we have appropriately low false negative rates, so we can safely spare axillary dissection if there is no cancer in the lymph nodes. We won't go through, there's a lot of animation. The last trial that we're eagerly awaiting the results of, because ultimately, frequently in our practice, myself and my colleagues have women who have neoadjuvant chemotherapy, whether for high oncotype mammoprint or because of the nature of their cancer. They have excellent responses. We take them to surgery and there is a very small amount of residual disease in one of their lymph nodes. Based on the data we have today, we have to dissect them. That's our standard of care. It's the right thing to do. And, you know, I know that we all struggle when we sit in front of that patient. We say, great news. The only positive lymph node you had was the one we knew about before surgery. And also we've taken 20 lymph nodes out and we know that your risk of lymphedema is high. You'll need physical therapy, all these things. So Alliance 11202 is going to help answer the question for us. Do we need to do axillary lymph node dissection in very low volume axillary disease, or is axillary radiation with Dr. Evans and her colleagues enough? I'll end there to leave time for our med-onc colleagues. Thanks for your attention. Nope. Oh, that's Sue.
Thank you so much. So much to discuss, and I know we're running out of time, and I want to make sure medical oncology colleagues can also give you a flavor of some of our controversies as well. So we have Dr. Andrea Silber and Dr. Adriana who will co-present. And if we could have some help to make sure this comes up.
Might be later on that slideshow. That looks like it might have been the design.
All right, should go ahead.
I think it's coming.
Okay.
If you post cards, there's 60 slides. So I think it.
There it is. 20.
Yeah, that
That's
same
right.
one.
Nope, not below that. This is how we rely on our surgical colleagues.
There we go.
Adriana and I are going to talk about two women who have a similar problem and different results, and we did different things. So the first patient is a 58-year-old Asian patient who had an abnormal screening mammo in 2024. Her breasts were dense. She had a new mass at 1 o'clock in the left breast, 7 centimeters from the nipple. It was best seen on ultrasound, and it was 1.8 centimeters in size. So that makes her a stage 1. Additional imaging was done. She ultimately had a biopsy and had an invasive ductal carcinoma, triple negative in type. It was grade 3. She had no axillary adenopathy, either on imaging or on exam. Genetic testing did not show any mutation. She's a healthy woman except for mild asthma. And that's her story. We're going to go to the next patient who, case 2, 69-year-old white female patient. She had an abnormal screening mammogram in November 2023, had a focal asymmetry in the lateral left breast, and follow-up diagnostic imaging showed a 1.2 by 1 by 1.4 centimeter spiculated lesion at 2 o'clock. The pathology, very similar to the last one, triple negative. She grade 2 to 3. She had no axillary adenopathy. She had no mutation, generally healthy hypertension and hyperlipidemia. And here's where Adriana is going to come in and help us decide what to do with these two similar women, but different women.
Thank you, Dr. Silber. I wish I could know the answer to that question. And it is something certainly that varies a lot between providers, between guidelines. So it's a very gray zone, the T1C triple negative breast cancer world. But I listed here some options of things that had been done or could be done. So one option for anyone to think is, would you just do surgery and be done with it? No, necessarily no systemic therapy. Would you start with surgery, being that it's a T1C tumor, and decide your adjuvant therapy after, and you can discuss at that point during TC chemotherapy versus ACT chemotherapy? Or do you think that this is a large enough tumor that requires neoadjuvant chemotherapy, and then you have options to do full chemotherapy with ACT versus a shorter course of chemotherapy, and then decide about further therapies in the adjuvant setting, depending on that response to the neoadjuvant approach? And then we have the bulkiest and fuller regimen we use so far for patients with triple-negative breast cancer, which is the Keynote 522 regimen, which is chemo and immunotherapy, currently not including patients in this stage. So patients that were included in this study were T2 or N positive disease, T2 or more. But we see that these options, although not all of them are agreed by all and not all of them are standard of care, are things that we see patients getting from different providers in different settings. So it's a gray zone, and that's when we struggle because of the lack of data for these smaller size tumors. So first question I would say is, do we need systemic therapy? So for T1 triple-negative breast cancers, they are rarely included in systemic therapy trials. So the analysis and the outcomes of these patients are much based on retrospective analysis. And as far as I can see, the largest analysis retrospectively that has been done, it's a SEER database analysis for patients with T1 triple-negative breast cancers. It's about 8,000 patients that had surgery up front that did not receive any systemic therapy in the neoadjuvant setting. And later they split these patients between the ones that did chemotherapy, the ones that did not do chemotherapy, and they broke that down by T1 substage. So T1 microscopic, T1A, which is up to 5 millimeters, T1B 5 to 10, and T1C more than 1, less than 2 centimeters. And ultimately, the conclusion is that T1 microscopic, T1A, and T1B did not seem to benefit that much from the addition of chemotherapy. Those patients had small size tumor with a smaller risk of systemic recurrence, that it seems that systemic therapy did not add much benefit to those patients. And therefore, it sounds by this that it could be less justifiable to offer patients chemotherapy with smaller tumors like T1B tumors, for example, which is also a gray zone. We see this question happening often in tumor boards and different opinions. Some oncologists feel like there should be a breakdown of T1B, kind of like if it's a T1B smaller or a T1B larger. So there's a lot of question marks, because we know that the patient doesn't change their category from going from one step to downhill just because the tumor went from 5 to 6 millimeters. We understand that there are differences in terms of outcomes being more gradual than necessarily like a stepwise approach as we do in staging. So that makes people question if this data is accurate enough for the higher sizes of T1Bs. But at least from the data that we see in the retrospective analysis, it does not seem to justify, if you have a smaller tumor, less than a T1C, to offer systemic therapy. So I just decided to bring that in. For sure, this is up to further discussion. And then if you are to do chemotherapy for these patients, then which regimen would you choose? And the biggest discussion here would be between anthracyclines or not giving anthracyclines to patients. So we know that classically anthracyclines have been a big hallmark of better outcomes in breast cancer, and we know they play a big role. But we also know that they don't come for free. They don't come without toxicity. We know that there's a risk of leukemias, MDS. We know that there's a risk of heart failure longer term. So do we think that everyone actually needs anthracyclines, or do we think that there's a patient population that might be fine without it? And then we have adjuvant data on the ABC trials and anthracyclines in breast cancer, questioning that, do everybody need anthracycline or not? And it's hard to make conclusions of larger studies too, because they have heterogeneity in their population, mixing triple negatives and hormone positives with all stages. And these studies, they do give us a breakdown of subtype and stage. And if we see the data on patients with smaller, no negative, triple negative breast cancers, it does seem like there's a 3% benefit of anthracyclines, but without a significant hazard ratio. So that makes us question, is this 3% benefit real? Should we be offering patients with smaller triple negative tumors a bunch of chemotherapy with ACT? Are all patients the same? We can also measure their risk factors, their potential of complications, their age, expectancy of complications to occur. So again, this is not a clear-cut zone, and guidelines even, they are dual. So we read ESMO guidelines, ASCO guidelines, St. Gallen guidelines, and they're all saying TC or ACT, debate with the patient, discuss with the patient. So we still don't have a firm decision or a recommendation uniformly because of the lack of data, basically. So no one can make any hard assumptions. So again, this is a very individual patient discussion. Do you want to get more therapy and maybe that's not needed, but maybe that can help you more, or you don't want to buy those toxicities and just be done with a therapy that seems to be equivalent. So there's a lot of individualization of choices. Another argument that can come to mind to see, like, should we give chemotherapy before or after surgery? We know that chemotherapy, if the same chemotherapy is given, if it's given before or after surgery, there's no big difference in outcomes. Patients are getting the same systemic therapy. But we know that we might be able to tailor therapy in triple-negative breast cancers depending on their response. If patients respond and their tumors are gone, they go to surgery, you might be done with them and they don't need more systemic therapy. Whatever you gave them was enough. Versus if you do some sort of therapy and there is residual cancer, that might mean that your chemotherapy wasn't able to kill the whole cancer. So that some patients might benefit from a rescue chemotherapy or another type of agents after their surgery is done. So I decided to look into the data of what we have currently available for residual disease therapy in triple-negative breast cancer. And a major drug we have currently is capecitabine in the CREATE-X trial. That trial showed improvement of disease-free survival if you give chemotherapy to patients with residual disease after neoadjuvant chemotherapy. So they get their neoadjuvant, they got their surgery, residual disease. Yes, they did seem to have a benefit, especially the triple-negative population, in getting adjuvant capecitabine. But when we go through the subgroups again, not large amounts of patients, but we need to see if we can understand that to individualize patient decision. Patients that had tumors less than 2 centimeters at diagnosis, they do not seem to have the same benefit of patients that had larger tumors at diagnosis. So again, it doesn't seem like the addition of capecitabine would justify giving therapies in the neoadjuvant setting to try to rescue them with capecitabine if the tumors were small to begin with. So they might be just fine with getting their surgeries and getting their therapies in the adjuvant setting without having to do chemotherapy twice in their lifetime. But we know that this is the truth today, at least through the data we have for capecitabine, but we know that we have tons of clinical trials with novel drugs, with ADCs, trying to answer that question. Okay, we know that we didn't do that great with capecitabine, but capecitabine might not be your best choice. Maybe you have a better drug that is gonna treat the residual disease better than capecitabine. So that's why this truth is truth here, but not truth for the concept of this process. So we, for sure, are eager to see future data with the trials we have in this setting. And then another drug we have is for patients with olaparib, patients with germline BRCA1 and 2 mutations. So for those patients, giving olaparib after residual disease is seen in the pathology can also improve their outcomes. If they do surgery first, they need to have much larger disease to qualify for olaparib based on the study. So they would have needed to have node positive or T2 or more disease. But if they had smaller tumors to begin with, and you give neoadjuvant therapy and they do have residual disease, then they qualify for olaparib. So in that context of a patient with BRCA mutations, you might individualize that discussion and say, yes, it doesn't seem like chemotherapy before would make a big difference itself in your outcome, but that might qualify you to olaparib if you have residual disease. So for those subset of patients, it might be worth discussing giving them chemotherapy in the neoadjuvant setting. Again, gray zone, not a lot of consensus or data, but those are just little things that I wanted to bring up, that sometimes subgroup analysis might help us individualize decisions. And the other question is, how can we predict better? Like we saw these 2 patients that we had, that Dr. Silber just presented. Similar cases, are there any other biomarkers that we can use to know one from the other, to know who needs more or less? We are happy to see that there are some data coming for triple-negative breast cancer in this setting, and one of them is tumor-infiltrating lymphocytes. We know patients that have higher levels of tumor-infiltrating lymphocytes, they have better outcomes. Those patients might need less therapy because with whatever little therapy they have, they already do great, versus if they have not as much tumor-infiltrating lymphocytes, you might need to add on therapies to them. So that could be a predictive test that can be used in the future. And also the presence of circulating tumor DNA and seeing if that circulating tumor DNA gets cleared as you treat them. So this is a nice study showing that if you were positive for ctDNA, circulating tumor DNA, before your neoadjuvant therapy, you proceeded with your neoadjuvant therapy and your circulating tumor DNA cleared, you had much higher rates of PET-CR, pathologic complete response, than if your ctDNA remained positive despite your systemic therapy, that those patients had more residual disease. So maybe one can create a clinical study that says, if you don't clear your circulating tumor DNA before your surgery, maybe this chemotherapy you received is not enough. Treat with some more before even the surgery, so that we can try to improve your rates of pathologic complete response. Or do additional therapies in the adjuvant setting? So all of those are questions that are being asked and being studied, and we hope to have those answers in the future. And then just last point is the role of immunotherapy. We know that this is approved in the neoadjuvant setting for larger triple-negative tumors, but when it comes to the small T1 tumors, they were mostly excluded from all of these trials. We have one trial that, and the trials that have done assessment of immunotherapy in the adjuvant setting had not been positive. We have one trial that includes patients with 1 centimeter or more, which is the SWOG 1418 study. This study has concluded accrual but pending results. So we can see later if this study shows positive results, maybe those patients with small tumors could get, if they have residual disease, they could get adjuvant pembrolizumab in the adjuvant setting, still being smaller initial tumors. So just an overall idea of what's trending. Eliminating anthracycline is a big question. Then we have current studies asking that question, including T1 triple-negative breast cancers. ADCs are a big thing. They're showing repeatedly to be stronger in terms of response rates and outcomes than chemotherapies. So they have been trying to replace a lot of the pre-therapies, the neoadjuvant and the adjuvant therapies in this patient population. And some of these new studies are including smaller tumors. And like we discussed, using TILs and circulating tumor DNA to answer some unanswered questions would be key. So back to our cases, things not always happen as we expect. So this first case, both of them had the same T1C. The first patient received neoadjuvant chemoimmunotherapy because clinically, though her tumor was 1.8, it seemed clinically that the tumor was larger, so treating physician opted to do chemoimmunotherapy. Patient did poorly with that. She couldn't tolerate this very well, so then that needed to be interrupted. And then case number 2 was a woman that followed the guideline. If it's a T1C 1.4 tumor, go to surgery first, and then she had a 2.4 centimeter tumor in her surgery. So the tumor size was different than the tumor size estimated by imaging. She would have qualified for the whole chemoimmunotherapy if she had treated before. Now she's post, and we know that the data in the adjuvant setting for immunotherapy is not as strong. So this patient maybe missed the chance of having the optimal therapy she should have had in the neoadjuvant setting, but it's something that could not be predicted because you just go by what you have in the preclinical, in the pre-surgical setting. You don't know the sizes ultimately. So unfortunately, we need clinical trials to answer unanswered questions. We need better biomarkers. We need better drugs. We need less toxic drugs. And we need strategies to understand who's who and who would benefit from what so that we don't have to guess and based on our best clinical judgments that not always are perfect. So we would hope that clinical trials could answer that question, and we encourage all to enroll patients because that's how we move science forward. Thank you so much.
Concludes the breast section. Thank you for listening. Dr. Herbst.
Okay, everyone gets extra CME credits for staying. Some of you don't care about them, do you? But for those, Nikolai, extra credit for asking a question.
I asked my question.
So listen, it's been a great day. I've listened to most of it, and I can tell you that we have a super duper program here in Connecticut and New Haven, and God forbid you have a cancer or a friend has cancer. I think there's every area that you could refer someone to for multimodality care across the network. I think next year, I have a soft spot in my heart. Now I'm going to give the heme another hour or two next year. And so we might even do a separate day, but I think it's actually good to have it all in one day because many people do both. So that's coming. Maybe we'll even include a little benign heme breakout in the back, and we can have Bloody Mary or something like that. But listen, it's been a great day. I thank you all. I want to thank my organizing committee. I have Scott Huntington right here. Thank you, Scott. Dr. Evans has been around all day. Where's Dr. Evans? She's on her way to ASTRO. And Kiran Taraga, who's at the surgical retreat. He couldn't leave the surgical retreat. I wrote him a note, but it didn't work. And then we have our other Pam Coons, who was here this morning, and she'll be back. So anyone have any questions or comments? For those doing CME, you have a chance to give suggestions. For others, you can send me suggestions as well. We'll be back here again next year. For those from the Yale group, we're going to hang out here a little bit and frolic and celebrate the day. Thank you to all the exhibitors and sponsors. We couldn't do it without you. It was great to see many of you. And I hereby officially declare this Yale review closed. Thank you.